Hi guys, so this is the take of Group 12, Ali, Caparos, and Martinez on the report of feeding and eating disorders under the DSM-5. Now, before we proceed to the discussion proper, I have to tell you that on the description box, I have attached their links of the documentaries of the disorders that will be presented in this video. So you will have an idea of how these disorders really work on the people who are having it. Now, I have to emphasize on the feeding and eating disorders that feeding or eating related behavior that results in the altering consumption or absorption of food that significantly impairs physical health or psychosocial functioning is the main point of feeding and eating disorders. Now, the diagnostic criteria are provided for Pica, Rumination Disorder, Avoidant Restrictive Food Intake Disorder, Anorexia Nervosa, Bulimia Nervosa, and Binge Eating Disorder. Now, the diagnostic for all of the disorders, excluding the Pica, actually result in the classification scheme that is mutually exclusive, so that during a single episode, only one of these diagnoses can be assigned. Now, the rationale for this approach is that despite a number of common psychological and behavioral features, the disorders differ substantially in clinical course, outcome, and treatment needs. A diagnosis for Pica, however, may be assigned in the presence of other feeding or eating disorder. And final note before we take the different disorders under this category is that obesity is not included in the DSM-5 as a mental disorder. Why? Because obesity is an excess body fat, which is resulted from a long-term excess of energy intake relative to energy expenditure. And a range of genetic, physiological, behavioral, and environmental factors that vary across individuals contribute to the development of obesity. Thus, obesity is not considered a mental disorder. However, there are robust associations between obesity and the number of mental disorders such as the binge eating disorder and depressive and bipolar disorder, and on the least case, the schizophrenia, and the side effect of some psychotropic medications also importantly contribute to the development of obesity, and that obesity may be a risk factor for the development of some mental disorders such as depressive disorders. Now we move to the first disorder under feeding and eating category, which is the Pica. And the Pica have 4 different diagnostic criteria. First on the list is persistent eating of non-nutritive non-food substances over the period of at least 1 month. Second on the list is the eating of non-nutritive non-food substances is inappropriate to the development level of an individual. And the third, it says here that the eating behavior is not part of a culturally supported or socially normative practice. And the fourth, if the eating behavior occur in the context of another mental disorder, such as intellectual disability, on the intellectual developmental disorder, autism spectrum disorder, or schizophrenia, or medical condition that includes pregnancy, it is sufficient or sufficiently severe to warrant additional clinical attention. Also, take note that the Pica on the ICD-9 has a code of 307.52 that are used for both children and adults, but later on the ICD-10-CM, codes for Pica are F98.3 in children and F50.8 in adults. Now, specify if in the remission after full criteria of Pica were previously met, the criteria have not been met for a sustained period of time. Now let's move to the more details. The diagnostic features tell us that the essential feature of Pica is the eating of 1 or more non-nutritive non-food substances on a persistent basis over a period of at least 1 month to satisfy the criterion A, and that is severe enough to warrant clinical attention. Now, typical substances ingested tend to vary with ages and availability of these substances that might include paper, soap, cloth, soil, chalk, talcum powder, or paint, or clay, and even ice. Now, the term non-nutritive is included because the diagnosis of Pica does not apply to ingestion of diet products that have minimal nutritional content. There is typically no aversion of food in general. Now, to meet the second criterion and the third criterion, we have to know that the eating of non-nutritive non-food substances must be developmentally inappropriate and not a part of culturally supported or socially normative practice. Also, it is said here that a minimum age of 2 years is suggested for Pica diagnosis to exclude developmentally normal mouthing of object by infants that result in ingestion. Now, to satisfy the criterion D, the eating of non-nutritive non-food substances can be associated feature of another mental disorder, again, such as the intellectual disability, autism spectrum disorder, and schizophrenia. But if the eating behavior occurs exclusively in the context of another mental disorder, then a separate diagnosis for Pica should be made only if the eating behavior is sufficiently severe enough to warrant additional clinical attention. Now, in the associated features supporting diagnosis, although the deficiencies in vitamins or minerals like zinc and iron have been reported in some instances, often no specific biological abnormalities are found. In some cases, Pica comes to clinical attention only following general medical complications such as mechanical bowel problems, intestinal obstruction such as the resulting from benzoate, and intestinal perforation, and infections such as toxoplasmosis and toxocariasis as a result of ingesting feces or dirt, and poisoning such as by ingestion of lead-based paints. Now, the prevalence for Pica is unclear. Among individuals with intellectual disability, the prevalence of Pica, however, appears to increase with the severity of the condition. Now, on the developmental course, onset of Pica can occur in childhood, adolescence, or adulthood, although in childhood onset is most commonly reported. Now, Pica can occur otherwise normally developing children, whereas in adults, it appears more likely to occur in the context of intellectual disability or other mental health disorders. Now, the eating of non-nutritive, non-food substances may also manifest in pregnancy when specific cravings, let's say chalk and or ice, might occur. The diagnosis for Pica during pregnancy is only appropriate if such cravings led to the ingestion of non-nutritive non-food substances to an extent that the eating of these substances poses potential medical risk. Now, the course of the disorder can be protracted and can result in medical emergencies such as intestinal obstruction, acute weight loss, and even poisoning. The disorder can potentially be fatal depending on the substances ingested. Now, the risk and prognostic factor said here that the environmental or the neglect, the lack of supervision, and the developmental delay can increase the risk for this condition. It's also said here on the culture-related diagnostics that in some populations, the eating of earth or other seemingly non-nutritive substances can be believed to be spiritual, medicinal, or other social value. Now, in these cases, the third category or the third criteria for diagnostic criteria for this disorder is not met because it has said again that it should be not part of culturally supported or socially normative practice in order to include on the diagnostic criteria. Now, the gender-related diagnostic issues says here that the Pica actually occur in both male and female. It can occur in females, especially during pregnancy. However, little is known about the course of Pica in the postpartum period. Now we're down to the diagnostic markers. Now it says here that The abdominal flat plate radiography and ultrasound and other scanning methods may reveal obstruction related to Pica. Also, that blood tests and other laboratory tests can be used to ascertain levels of poisoning or the nature of infection. Functional consequences of Pica. Well, Pica can significantly impair physical functioning, but it is rarely the sole cause of impairment in social functioning. Pica often occur with other disorders associated with impaired social functioning. Now, the differential diagnosis says here that in addition, or the eating of non-nutritive or non-food substances may occur during the course of other mental disorders, let's say autism spectrum disorder, schizophrenia, and incline-Levin syndrome. Now, in any such instance, the additional diagnosis of Pica should be given only if the eating behavior is sufficiently persistent and severe enough to warrant additional clinical attention. So, first on the list is anorexia nervosa, where Pica can usually be distinguished from other feeding and eating disorders by the consumption of non-nutritive non-food substances. But it is important to note, however, that some presentation of anorexia nervosa, including ingestion of non-nutritive non-food substances, such as paper tissues, as a mean of attempting to control appetite. So in such cases, when the eating of non-nutritive non-food substances is primarily used as a means of weight control, then anorexia nervosa should be the primary diagnosis. Second is the factitious disorder. In some individuals with factitious disorder, may intentionally ingest a foreign object as part of the pattern of the falsification of physical symptoms. In such instances, objects are or the element of deception that is consistent with deliberate induction of injury of diseases. Now, on the non-suicidal self-injury and non-suicidal self-injury behaviors in personality disorders, some individuals may swallow potentially harmful items that includes the pins, needles, and knives in the context of maladaptive behavior patterns associated with personality disorders or non-suicidal self-injury. So, on the comorbidity, the disorders most commonly comorbid with Pica are autism spectrum disorder, intellectual disability under the intellectual developmental disorder, and to a lesser degree, schizophrenia and obsessive-compulsive disorder. Also, it has been said here that the Pica can be associated with trichotillomania or the hair pulling disorder and excoriation disorder like the skin peaking disorder. So in comorbid presentation, the hair or skin is typically ingested. Pica can also be associated with avoidant restrictive food intake disorder, particularly in individuals with a strong sensory component to their presentation. When an individual is known to have Pica, the assessment should include consideration of the possibility of gastrointestinal complication, poisoning, infection, and some nutritional deficiency. Now we're up to the second disorder under the feeding and eating category, and this is the rumination disorder with 4 different diagnostic criteria, and the code for the rumination disorder on the ICD-9 is 307.53, but on the ICD-10-CM it is F98.21. Now, it has been said on the first list of diagnostic criteria that the repeated regurgitation of food over a period of at least 1 month is the most essential feature of this disorder. Now, the regurgitated food may be rechewed, re-swallowed, or spit out. Second, the repeated regurgitation is not attributable to an associated gastrointestinal or other medical conditions such as gastroesophageal reflux or pyloric stenosis. The third, the eating disturbance does not occur exclusively during the course of anorexia nervosa, bulimia nervosa, binge eating disorder, or avoidant restrictive food intake disorder. Now, the last criterion, if the food or if the symptoms occur in the context of another mental disorder, such as intellectual disability under the intellectual developmental disorder, or another neurodevelopmental disorder, then they are sufficiently severe to warrant additional clinical attention. Also, we have to specify if in remission, after full criteria for rumination disorder were previously met, the criteria have not been met for a sustained period of time. Now, moving to the diagnostic features. Again, the most essential feature for rumination disorder is the repeated regurgitation of food occurring after feeding or eating over a period of at least 1 month to satisfy the first criterion. Now, previously swallowed food that may be partially digested is brought up into the mouth without apparent nausea, involuntary retching, or disgust. The food may be re-swallowed or re-chewed and then ejected from the mouth, or again, re-swallowed. The regurgitation in rumination disorder should be frequent, occurring at least several times per week, or typically daily. Now, in the behavior, or if the behavior is not better explained by associated gastrointestinal or other medical conditions such as gastroesophageal reflux or pyloric stenosis, then it satisfies the criterion B. And if it does not occur exclusively during the course of anorexia nervosa, bulimia nervosa, binge eating disorder, and avoidant restrictive disorder, so it will satisfy the criterion C. Now, to satisfy the last criterion, if the symptoms occur in the context of another mental disorder, such as intellectual disability, under the intellectual developmental disorder, or neurodevelopmental disorder, then they must be sufficiently severe enough to warrant additional clinical attention and should represent a primary aspect of the individual's presentation requiring intervention. The disorder may be diagnosed across a lifespan, particularly in individuals who also have intellectual disability. Many individuals with rumination disorder actually can be directly observed engaging in the behavior by the clinician. And in other cases, diagnosis can be made on the basis of self-report or corroborative information from parent or caregivers. Now, individuals who have the rumination disorder may describe the behavior as habitual or outside of their control. Associated features supporting diagnosis tell us that infants with rumination disorder display a characteristic of position of straining and arcing the back with the head held back, making sucking movements with their tongue. Now, people or individual with rumination disorder might tend to give an impression of gaining satisfaction from the activity. It has also been said that during the episodes of regurgitation, the person may be irritable or hungry, and weight loss and failure to make expected weight gains are common features in infants with rumination disorder. Malnutrition may occur despite the infant's apparent hunger, and the ingestion of relatively large amount of food, particularly in severe cases when regurgitation immediately followed after each feeding episode and regurgitated food is expelled. Now, malnutrition may also occur in older children and adults, particularly when the regurgitation is accompanied by the restriction of reswallowing the food. Adolescents and adults may attempt to disguise the regurgitation behavior by placing a hand over the mouth or coughing. Some will avoid eating with others because of the acknowledged social undesirability of the behavior. And this may extend to an avoidance of eating prior to a social situation such as work or school. For example, the avoiding breakfast because it may be followed by regurgitation. Now, the prevalence of rumination disorder is said to be inconclusive, but the disorder is commonly reported to be higher in certain groups, such as individuals with intellectual disability. The development and course will tell us the onset of rumination disorder can occur in infancy, childhood, adolescent, or even adulthood. The age at onset in infants is usually between the ages of 3 and 12 months. Now, in infants, the disorder frequently remits spontaneously, but its course can be protracted and can result in medical emergencies like severe malnutrition, and it can potentially be fatal, particularly in infancy. The rumination disorder can have an episodic course or occur continuously until treated. Now, in infants as well as in older individuals with intellectual disability, like said again, the intellectual developmental disorder or other neurodevelopmental disorders, the regurgitation and rumination behavior appears to have a self-soothing or self-stimulating function, similar to that of the repetitive motor behavior such as head banging. Now, on the risk and prognostic factors, it is said here that it is environmental or the psychosocial problem such as lack of stimulation, neglect, stressful life situation, and problems in the parent-child relationship may be predisposing factor in the infants and young children. Functional consequences of rumination disorder are the malnutrition secondary to repeated regurgitation, that may be associated with growth delay and have negative effect on the development and learning potential. And some older individuals with rumination disorder deliberately restrict their food intake because of the social undesirability of regurgitation, and they may therefore present with weight loss or low weight. And in older children, adolescents, and adults, social functioning is more likely to be adversely affected. On the differential diagnosis, we have the gastrointestinal condition. It is important to differentiate regurgitation and rumination disorder from other conditions characterized by gastroesophageal reflux or vomiting. Conditions such as gastroparesis, pyloric stenosis, hiatal hernia, and Standifer syndrome in infants should be ruled out by appropriate physical examination and laboratory tests. On the anorexia nervosa and bulimia nervosa, individuals with these disorders may also engage in regurgitation with the subsequent spitting out of food, but as a means of disposing of ingested calories because of the concern about weight gain. Now, the comorbidity that is common with regurgitation is the medical condition or other mental disorders such as generalized anxiety disorder. When the regurgitation occurs in this context, a diagnosis of rumination disorder is appropriate only when the severity of the disturbance exceeds the routinely associated with such conditions or disorder that and warrant additional clinical attention. Now we're up to the third disorder under the feeding and eating category, which is the avoidant restrictive food intake disorder, with 4 diagnostic criteria, but under the first criterion, we have 4 additional sub-criterions or subcriteria. Now, for the ICD-9, the code for avoidant restrictive food intake disorder is 307.59, but for the ICD-10-CM, it's F50.8. Now, on the first list of diagnostic criteria, an eating or feeding disturbance like apparent lack of interest in eating or food, avoiding based on the sensory characteristic of food, concerning about aversive consequences of eating as manifested by persistent failure to meet appropriate nutritional and or energy needs associated with one or more of the following. First is significant weight loss or failure to achieve expected weight gain or faltering growth in children. Second is significant nutritional deficiency. Third, difference on the enteral feeding or dependence on the enteral feeding or oral nutritional supplements. And fourth, marked interference with psychosocial functioning. Now, on the second diagnostic criteria, we have the disturbance is not better explained by the lack of available food or by associated culturally sanctioned practice. Later, we will be having an in-depth details or discussion to it on the diagnostic features. But let us proceed for now to the third diagnostic criteria. The eating disturbance does not occur exclusively during the course of anorexia nervosa or bulimia nervosa, and there is no evidence of the disturbance in the way in which one's body weight or shape is experienced. The eating disturbance is not attributable to the concurrent medical condition or not better explained by any other mental disorder. When the eating disturbance occurs in the context of another condition or disorder, the severity of the eating disturbance exceeds the routinely associated with the condition or disorder and warrants additional clinical attention. Also, specify if in remission after full criteria of avoidant restrictive food intake disorder were previously met, the criteria have not been met for a sustained period of time. Now, the diagnostic features, it tells us that the main diagnostic feature of avoidant restrictive food intake disorder is the avoidance or restriction of food intake, manifested by clinically significant failure to meet requirements for nutrition or insufficient energy intake through oral intake of food. One or more of the following key features may be present: the significant weight loss, significant nutritional deficiency, or related health impact, the dependence of enteral or dependence on enteral feeding or oral nutritional supplements, or marked interference with psychosocial functioning. It is also said in the Criterion A sub 1 that the determination of whether weight loss is significant is a clinical judgment. Instead of losing weight, children and adolescents who have not completed growth may not maintain weight or height increase along their developmental trajectory. On the Criterion A sub 2, determination of significant nutritional deficiency is also based on a clinical assessment, like the assessment of dietary intake, physical examination, and laboratory testing, and related impacts on physical health can be of a similar severity to that seen in anorexia nervosa, like hypothermia, bradycardia, and anemia. Now, on the Criterion A sub 3, in severe cases, particularly in infants, malnutrition can be life-threatening. So the dependence rather of an enteral food or oral nutrition supplements means that supplementary feeding is required to sustain adequate intake. Example of individuals requiring supplementary feeding includes the infant with failure to thrive who require nasogastric tube feeding, and children with neurodevelopmental disorders who are dependent on nutritionally complete supplements, and also in the individuals who rely on gastrostomy tube condition. Inability to participate in normal social activities such as eating with others or to sustain relationship as a result of disturbance would include marked interference with psychosocial functioning as said on the Criterion A sub 4. Now, on the avoidant restrictive food intake disorder, to satisfy the Criterion B, C, and D, this disorder does not include avoidance or restriction of food intake related to lack of availability of food or to cultural practices such as religious fasting or normal dieting. Nor does it include developmentally normal behaviors such as picky eating in toddlers and reduced intake in older adults. So the disturbance is not better explained by excessive concern about body weight or shape or by concurrent medical factor or mental disorders. In some individuals, food avoidance or restriction may be based on the sensory characteristic of the qualities of food, such as extreme sensitivity to appearance, color, smell, texture, temperature, or taste. So such behaviors has been described as restrictive eating, selective eating, choosy eating, or preservant eating, or even chronic food refusal and food neophobia. And this may manifest as refusal of eating particular brands of food or to tolerate the smell of food being eaten by others. Individuals with heightened sensory sensitivity associated with autism may show similar behaviors. Now, the food avoidance or restriction may also present in the conditioned negative response associated with food intake following or in anticipation of an adverse experience, such as choking, a traumatic investigation, usually involving a gastrointestinal tract, or like esophagoscopy, or repeated vomiting. So the term function dysphagia and globus hystericus have also been used for such conditions. Now, on the associated features supporting diagnosis, several features may be associated with food avoidance or reduced food intake, including the lack of interest in eating or food, leading to weight loss or faltering growth. Now, very young infants may present as being too sleepy, distressed, or agitated to feed. Infants and young children may not engage with the primary caregiver during feeding or communicate hunger in the favor of other activities. In older children and adolescents, food avoidance or restriction may be associated with more generalized emotional difficulties that do not meet diagnostic criteria for an anxiety, depressive, or bipolar disorder, and sometimes called food avoidance emotional disorder. Now, on the developmental course, food avoidance restriction associated with insufficient intake or lack of interest in eating most commonly develops in infants or early childhood and may persist in adulthood. Likewise, avoidance based on the sensory characteristic of food tends to arise in the first decade of life but may persist into adulthood. So, avoidance related to aversive consequences can arise at any age. Now, infants with avoidant restrictive food intake disorder may be irritable and difficult to console during feeding or may appear apathetic and withdrawn. And in some instances, parent-child interaction may contribute to the infant's feeding problem, like the presenting food inappropriately or interpreting the infant's behavior as an act of aggression or rejection. Inadequate nutritional intake may exacerbate and associated features like irritability, developmental lags, and further contribute to feeding difficulties. So the avoidant restrictive food intake disorder manifests more commonly in children than in adults, and there may be a long delay between onset and clinical presentation. Triggers for presentation vary considerably and include physical, social, and emotional difficulties. So on the risk and prognostic factors, we have three. First is the temperamental. Anxiety disorders, autism spectrum disorder, obsessive-compulsive disorder, and attention deficit hyperactivity disorder may increase the risk of avoidant or restrictive feeding or eating behavior characteristic of the disorder. Environmental risk factors for avoidant restrictive food intake disorder include familial anxiety, and higher rates of feeding disturbances may occur in children of mothers with eating disorders. Non-genetic and physiological, history of gastrointestinal condition, gastroesophageal reflux disease, vomiting, and a range of other medical problems has been associated with feeding and eating behavior characteristic for avoidant restrictive food intake disorder. Moving on, we have the culture-related diagnostic issues. So, the presentation similar to avoidant restrictive food intake disorder occur in various populations, including in the United States, Canada, Australia, and Europe. So, avoidant restrictive food intake disorder should not be diagnosed when avoidance of food intake is solely related to specific religious or cultural practices, again, like intermittent fasting. So, on the gender related diagnostic, avoidant restrictive food intake disorder is equally common in males and females, actually, in infancy and early childhood. But avoidant restrictive food intake disorder, comorbid with autism spectrum disorder, has a male predominance. And food avoidance or restriction related to alter sensory sensitivities can occur in some physiological conditions, most notably pregnancy, but is not usually extreme and does not meet full criteria for the disorder. So on the diagnostic markers, it includes the malnutrition, the low weight, growth delay, and the need for artificial nutrition in the absence of any clear medical condition other than poor intake. On the functional consequences of this disorder, the associated developmental and functional limitation include impairment of physical development and social difficulties that can have a significant negative impact on the family function. Now going to the differential diagnostics, appetite loss preceding restricted intake is non-specific symptom that can accompany a number of mental diagnoses. Avoidant restrictive food intake disorder can be diagnosed concurrently with the disorder below if the criteria are met, and the eating disturbance requires specific clinical attention. Now, other medical conditions like gastrointestinal disease, food allergies, and intolerances or occult malignancies. It says here that the restriction of food intake may occur in other medical conditions, especially those with ongoing symptoms such as vomiting, loss of appetite, nausea, abdominal pain, or diarrhea, and underlying medical or comorbid mental conditions may complicate feeding and eating because older individuals, post-surgical patients, and individuals receive chemotherapy often lose their appetite. Specific neurological, neuromuscular, structural, or congenital disorders and conditions associated with feeding difficulties says that feeding difficulties are common in the number of congenital and neurological conditions, often related to problems with oral, esophageal, pharyngeal structure and functions, such as hypotonia and musculature tongue protrusion and unsafe swallowing. So, retractive attachment disorder, some degree of withdrawal in characteristic of reactive attachment disorder can lead to the disturbance in the caregiver-child relationship that can affect feeding and the child's intake. Avoidant restrictive food intake disorder should be diagnosed concurrently only if all criteria are met for both disorders and the feeding disturbance is a primary focus for intervention. On the autism spectrum disorder, individuals with autism spectrum disorder often present with rigid eating behaviors and heightened sensory sensitivities. However, these features do not allow result in the level of impairment that would be required for a diagnosis of avoidant restrictive food intake disorder. Specific phobia, social anxiety disorder, or the social phobia, and other anxiety disorders tell us that specific phobia or other types that specify situation that may lead to choking or vomiting can represent a primary trigger for the fear, anxiety, or avoidance required for the diagnosis. Distinguishing specific phobia from avoidant restrictive food intake disorder can be difficult when the fear of choking or vomiting has resulted in food avoidance. On the anorexia nervosa, says here that the restriction of energy intake relative to requirements leading to significantly low body weight is the core feature of anorexia nervosa. Later we will be discussing that. However, individuals with anorexia nervosa also display a fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain, as well as specific disturbances in relation to perception and experience of their own body weight and body shape. Now, on the obsessive compulsive disorder, it tells us that individual with this disorder may present with avoidance or restriction to intake in relation to preoccupation with food or ritualized eating behavior. On the major depressive disorder, on the other hand, in major, the appetite might be affected to such an extent that individuals present with significantly restricted food intake, usually in relation to overall energy intake and often associated with weight loss. Usually, appetite loss and related reduction of intake abate with resolution of mood problems. Now, on the schizophrenia spectrum disorder, individuals with schizophrenia, delusional disorder, or other psychotic disorders may exhibit odd eating behaviors, avoidant of specific food because of delusional beliefs, or other manifestations of avoidant or restrictive intake. Now, in some cases, delusional beliefs may contribute to the concern about negative consequences of ingesting certain food. And last on this differential diagnosis is the factitious disorder or factitious disorder imposed on another. In order to assume the sick role, some individual with factitious disorder may intentionally describe diets that are much more restrictive than those that are actually able to consume, as well as complications of such behavior, such as the need for enteral feeding or nutritional supplements and inability to tolerate a normal rate of food, or an inability to participate normally in age-appropriate situations involving food. So the presentation may be impressively dramatic and engaging, and the symptoms report inconsistently. So on the last part of this disorder, the comorbidity, the most common observed disorders comorbid with this disorder, the avoidant restrictive food intake disorder, are anxiety disorders, obsessive-compulsive disorders, and neurodevelopmental disorders, specifically autism spectrum disorders and attention deficit hyperactivity disorder, and even intellectual disability under the intellectual developmental disorder. So we are down to the fourth disorder under the feeding and eating category, which is the anorexia nervosa. Now, the diagnostic criteria for this disorder are only three, and later I will be discussing the coding note. But first, we have to discuss the three different diagnostic criteria under anorexia nervosa. First is restriction of energy intake relative to requirements, leading to significantly low body weight in the context of age, sex, developmental trajectory, and physical health. Significantly low weight is defined as a weight that is less than minimally normal, or for children and adolescents, less than the minimally expected. Now, on the second list is the diagnostic criteria for anorexia nervosa have an intense fear of gaining weight or becoming fat, as being said on the differential diagnosis on the previous disorders under this category, or persistent behavior that interferes with weight gain or even though at a significantly low weight. Now, the diagnostic criteria on the third of the list, the disturbance in a way in which one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or persistent lack of recognition of the seriousness of the current low body weight. Now, as said a while ago, the coding note for ICD-9-CM is 307.1, which is assigned regardless of the subtypes. Now, on the ICD-10-CM, codes depend on the subtypes, which I am going to tell you right now. You have to specify because there are two subtypes of anorexia nervosa. First is the restricting type, and second is the binge eating type. Now, the ICD-10-CM code for restricting type is F50.01. So what is restricting type? During the last 3 months, the individual has not engaged in recurrent episodes of binge eating or purging behavior, like self-induced vomiting or misuse of laxative, diuretics, or enemas. In subtypes, describe presentation in which weight loss is accomplished primarily through dieting, fasting, and or excessive exercise. Now, for the second subtype of anorexia nervosa, which is the binge eating or purging type, we have an ICD-10-CM code of F50.02. It says here that during 3 months or during the last 3 months, the individual has engaged in recurrent episodes of binge eating or purging behavior, such as self-induced vomiting or the misuse of laxative, diuretics, or enemas. So, in a clear or in a lighter sense, the restricting type do not engage in a recurrent episode of binge eating or purging behavior. And on the binge eating and purging behavior, of course, they engage in these behaviors. Also, specify if in partial remission after full criteria for anorexia nervosa was previously met, criterion A or the low body weight has not been met for a sustained period, but either criterion B, criterion C is still met. Or in full remission, after full criteria for anorexia nervosa were previously met, none of the criteria have been met for a sustained period of time. Also, specify the current severity. The minimum level for severity is based for adults on current body mass index or BMI, as you can see on the screen, and the ranges below derived from World Health Organization categories for thinness in adults. And for children and adolescents, corresponding BMI percentile should be used, seen also on the screen, and the level of severity may be increased to reflect clinical symptoms and the degree of functional disability and the need for supervision. Now, moving to the subtypes of anorexia nervosa, most individuals with the binge eating or purging type of anorexia nervosa who binge eat also purge through self-induced vomiting or the misuse of laxative, diuretics, or enemas. Some individuals with this subtype of anorexia nervosa do not binge eat but do regularly purging after the consumption of small amount of food. So the crossover between the subtypes over the course of the disorder is not uncommon. Therefore, subtypes description should be used to describe current symptoms rather than longitudinal course. So on the diagnostic features for both of the types, there are 3 essential features of anorexia nervosa: the persistent energy intake restriction, the intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain, and a disturbance in self-perceived weight or shape. Now, the individual maintains a body weight that is below a minimally normal level of age, sex, developmental trajectory, and physical health in the criterion A. Individuals' body weight frequently meet this criterion following a significant weight loss, but among children and adolescents, there may alternatively be failure to make expected weight gain or to maintain the normal development trajectory while growing in height. Instead of weight loss, In summary, in determining whether criterion A is met, the clinician should consider available numerical guidelines as well as individual's body weight, weight history, the body build, and the physiological disturbances. Also, to satisfy the second criterion of the anorexia nervosa, individuals with this disorder typically display an intense fear of gaining weight or becoming fat. Now, this intense fear of becoming fat is usually not alleviated by weight loss. In fact, concern about weight gain may increase even as weight fails or weight falls. So younger individuals with anorexia nervosa, as well as some adults, may not recognize or acknowledge the fear of weight gain. So to meet the criterion C, the experience and significance of body weight and shape are distorted in these individuals. So some individuals feel globally overweight, others realize that they are thin but are still considered that certain body parts. Or again, others realize that they are thin but still considers that certain body parts like cheeks or the buttocks. So particularly in the abdomen and in the thighs, and they are referring it to be too fat. And they may employ a variety of techniques to evaluate their body size or weight, including frequent weighing and obsessive measurement of body parts, like again the buttocks or thighs, and persistent use of the mirrors to check if perceived areas of fat. Now, the self-esteem of individuals with anorexia nervosa is highly dependent on their perception of body weight and body shape. Now, here on the associated features that are supporting diagnosis, we have the when some serious underweight may individuals or many individuals with anorexia nervosa have depressive signs and symptoms such as depressive mood, social withdrawal, irritability, insomnia, and diminished interest in sex. Because these features are also observed in the individuals without anorexia nervosa who are significantly undernourished, many of the depressive features may be secondary to the physiological sequelae of semi-starvation, although they may also be sufficiently severe to warrant an additional diagnosis of major depressive disorder. Now, on the second associated feature supporting the diagnosis, we have the obsessive-compulsive features. The observation, or both related and unrelated to food, are often prominent. Most individuals with anorexia nervosa are preoccupied with thoughts of food. Some collect recipes or hoard food. So observation of behaviors associated with other forms of starvation suggests that obsession and compulsion related to food may be exacerbated by undernutrition. When individuals with anorexia nervosa exhibit obsessions and compulsions that are not related to food, body shape, or weight, an additional diagnosis of obsessive-compulsive disorder may be warranted. Now, we also have other features sometimes associated with anorexia nervosa, which includes concerns about eating in public, feeling or ineffectiveness, and a strong desire to control one's environment, or even inflexible thinking and limited social spontaneity and overly restrained emotional expression. Now, compared with individuals with anorexia nervosa, restricting type, those with binge eating and purging type have higher rates of impulsivity and are more likely to abuse alcohol and other drugs. Individuals with anorexia nervosa may also misuse medications such as manipulating dosage in order to achieve weight loss or avoid weight gain. So individuals with diabetes mellitus may omit or reduce insulin doses in order to minimize carbohydrate metabolism. Now, on the prevalence of anorexia nervosa, the 12-month prevalence or the 1-year prevalence of anorexia nervosa among young female is approximately 0.4%, and less is known about the prevalence among the males. But anorexia nervosa is far less common in males than females, with a clinical population generally reflecting approximately in a 10:1 female-to-male ratio. And on the development and course of anorexia nervosa, it has been said here that anorexia nervosa commonly begins during adolescence or young adulthood. It rarely begins before puberty or after 40 or the age of 40, but cases of both early and late onset have been described. Now, the onset of this disorder is often associated with a stressful life event, such as leaving home for college. Yeah, and like that. The course and outcome of anorexia nervosa are highly variable. Younger individuals may manifest atypical features, including denying fear of fat. And some individuals with anorexia nervosa recover fully after a single episode, with some exhibiting a fluctuating pattern of weight gain followed by relapse, and others experiencing a chronic course over many years. Hospitalization may be required to restore weight and address medical complications, and most individuals with anorexia nervosa experiencing remission within 5 years of presentation. Among individuals admitted to hospitals, overall remission rates may be lower. The crude mortality rate, or the CMR, for anorexia nervosa is approximately 5% per decade. Now, death most commonly result from medical complications associated with the disorder itself and not from the suicide. So on these disorders, risk and prognosis factors, we have three: the temperamental, environmental, and the genetic and physiological. So for the temperamental, individuals who develop anxiety disorders or display obsessional traits in childhood are at increased risk of developing anorexia nervosa. On the environmental case, historical and cross-cultural variability in the prevalence of anorexia nervosa supports its association with cultures and setting in which thinness is valued. Occupation and avocation that encourage thinness, such as modeling like the Victoria's Secret Angel, and elite athletes are also associated with the increased risk of acquiring anorexia nervosa. Now, on the genetic and physiological, there is an increased risk of anorexia nervosa and bulimia nervosa among first-degree biological relatives of individuals with the disorder. An increased risk of bipolar and depressive disorders has also been found among first-degree relatives of individuals with anorexia nervosa, particularly related of individuals or relative of individuals with the binge eating and purging type. Now, on the culture-related diagnostic issues, anorexia nervosa occurs across culturally and socially diverse populations. Although available evidence suggests culture or cross-cultural variation in its occurrence and presentation. Now, anorexia nervosa is probably most prevalent in most industrialized, high-income countries such as in the United States and many European countries, Australia, New Zealand, and Japan, but its incidence in most low and middle-income countries is uncertain. Whereas the prevalence of anorexia nervosa appears comparatively low among Latinos, African Americans, and Asians in the United States. So clinicians should be aware that the mental health service utilization among individuals with an eating disorder is significantly lower in these ethnic groups, and that the low rates may reflect an discernment bias. But also the presentation of weight controls or weight concerns among individuals with eating and feeding disorders varies substantially across cultural contexts. The absence of an expressed intense fear of weight gain, sometimes referred to as a fat phobia. And it also appears to be relatively more common in the population of Asia. Now, on the diagnostic markers, we have 1, 2, 3, 4, 5, 6, 7. We have the 8 different disorders or conditions that we have to think or consider on the anorexia nervosa. So the following laboratory abnormalities may be observed in anorexia nervosa, but their presence may severe to increase the diagnostic confidence. First is the hematology. So leukemia is common with the loss of all cell types, but usually with the apparent lymphocytosis. So mild anemia can occur as well as thrombocytopenia and rarely bleeding problems. So in serum chemistry, dehydration may be reflected by an elevated blood urea nitrogen level. The hypercholesterolemia is common. Hepatic enzyme levels may be elevated, and hypomagnesemia or the hypozynesemia or hypophosphatemia and hyperamylasemia are occasionally observed in the course or in the presentation of anorexia nervosa. Now, self-induced vomiting may lead to metabolic alkalosis or the elevated serum bicarbonate, which it also said that the self-induced vomiting may also lead to the hypochloremia and hypokalemia. Laxative abuse may cause a mild metabolic acidosis. On the endocrine, serum thyroxine or the T4 level are usually in the low normal range, and triiodothyronine or the T3 levels are decreased, while reverse T3 levels are elevated. So females have low serum estrogen levels, whereas males have low level of serum testosterone. Now, on the electrocardiography, sinus bradycardia is common, and rarely arrhythmias are noted. Significant prolongation of the QTC intervention or interval is observed in some individuals. Now, on the bone mass, low bone mineral density with specific areas of osteopenia and osteoporosis is often seen on the presentation of the anorexia nervosa. Now, the risk of fracture is significantly elevated to people with this disorder. And electroencephalography or the electroencephalography diffuse abnormalities reflecting a metabolic encephalopathy that may result from significant fluid or electrolyte disturbances, resting energy expenditure. This is often a significant reduction of resting energy expenditure. Physical signs and symptoms also are the diagnostic markers for this disorder, that many of the physical signs and symptoms of anorexia nervosa are attributable to starvation. Amenorrhea is commonly presented and appears to be the indicator of physiological dysfunction. So if present, amenorrhea is usually a consequence of a weight loss, but not a minority of individuals. It may actually precede the weight loss. In prepubertal females, menarche may be delayed. And in addition to amenorrhea, there may be complaints of constipation, abdominal pain, cold intolerance, and lethargy and excess energy. So in some individuals, evidence of yellowing of the skin associated with hypercarotenemia as may be seen in the individuals with bulimia nervosa. Individuals with anorexia nervosa also self-induced vomiting and may have hypertrophy of the salivary glands, particularly in the parotid glands, as well as the dental enamel erosion. So some individuals may have scars or calluses on the dorsal surface of their hands from repeating contact with their teeth while inducing the vomiting. Now, there is a suicidal risk on this disorder, and it is elevated with the rates reported as 12 per 100,000 per year. So comprehensive evaluation of individuals with anorexia nervosa should include assessment of suicide-related ideation and behavior, as well as other risk factors for suicide, including a history of suicide attempts. Now, on the functional consequences of anorexia nervosa, individuals with anorexia nervosa may exhibit a range of functional limitation associated with the disorder. While some individuals remain active in social and professional functioning, others demonstrate significant social isolation and or failure to fulfill academic or career potentials. Now, on the differential diagnosis of anorexia nervosa, we have here at least the 1, 2, 3, 4, 5, 7. Have at least 7 differential diagnoses. So, other possible causes of either significantly low body weight or significantly low or significantly weight loss should be considered in a differential diagnosis of anorexia nervosa, especially when the presenting feature are atypical or let's say onset after the age of 40 years. Now, the medical conditions such as gastrointestinal disease, hyperthyroidism, occult malignancies, and acquired immunodeficiency syndrome or the AIDS, serious weight loss may occur in medical condition, but individuals with these disorders usually do not also manifest a disturbance in a way their body weight or body shape is experienced or not intense fear of weight gain or persist in behaviors that interfere with appropriate weight gain. Now, acute weight loss associated with medical condition can occasionally be followed by the onset of recurrence of anorexia nervosa, which can initially be masked by the comorbid medical condition. Rarely, anorexia nervosa develop after bariatric surgery for obesity. Next is the major depressive disorder. It tells here that in this disorder or the major depressive disorder, severe weight loss may occur, but most individuals with major depressive disorder do not have either the desire of excessive weight loss or an intense fear of gaining weight. So on the schizophrenia, individuals with schizophrenia may exhibit odd eating behavior and occasionally experience significant weight loss, but they rarely show the fear of gaining weight and that the body image disturbance required for the diagnosis of anorexia nervosa. So on the substance use disorders, the individuals with this may experience low weight due to poor nutritional intake, but generally do not fear gaining weight and do not manifest body image disturbance. On the social anxiety disorder or the social phobia, obsessive-compulsive disorder, and body dysmorphic disorder, some of the features of the anorexia nervosa overlap with the criteria of the social phobia, OCD, and the body dysmorphic disorders. Specifically, individuals may feel humiliated or embarrassed to be seen eating in public. As in social phobia, may exhibit obsession and compulsion related to food, and as in OCD, or may be preoccupied with an image or imagined defected or defect in bodily appearance, and as in body dysmorphic disorder. Now, in most of the differential diagnosis, you can see that the very enlightened feature of the anorexia nervosa that separates from all of them is the fear of gaining weight and or the disturbance in the body fat of the body. Now we have to proceed to bulimia nervosa, or the individuals with this disorder exhibit recurrent episodes of binge eating, engage in inappropriate behavior to avoid a food or weight gain, like self-induced vomiting, and are overly concerned with body shape and weight. However, unlike individuals with anorexia nervosa, binge eating and purging type, individuals with bulimia nervosa maintain a body weight and or above the minimally normal level. So, in the avoidant restrictive food intake disorder, so individuals with this disorder may exhibit significant weight loss or significant nutritional deficiency, but they do not have, again, the fear for gaining weight or of becoming fat, nor do they have the disturbance in a way they experience their body shape or body weight. So on the comorbidity that is common with anorexia nervosa, we have bipolar, depressive, and anxiety disorders that are commonly co-occur with anorexia nervosa. Many individuals with anorexia nervosa report a presence of either an anxiety disorder or symptoms prior to onset of their eating disorder. Now, OCD also is described in some individuals with anorexia nervosa, especially those with the restricting type. So alcohol use, disorder and other substance use disorders may also be comorbid with anorexia nervosa, especially among those with the binge eating and purging type. So we're down to the fifth disorder under the feeding and eating category, which is the bulimia nervosa, and we are near to finishing all the discussion under this topic. Now, for the diagnostic criteria under bulimia nervosa, we have 5 different listing under diagnostic criteria. But unlike the anorexia nervosa, the bulimia nervosa do not have the subtypes of the disorder, but has the level of severity. So that's why in the ICD-9 and 10, they only have one coding. So the code for the ICD-9 CM is 307.51, and for the ICD-10 CM, it's F50.2. Now let's go to the discussion of the diagnostic criteria. So a recurrent episode of binge eating. An episode of binge eating is characterized by both of the following. First is eating in a discrete period of time, like let's say within any 2-hour period of time, and amount of food that is definitely larger than what most individual would eat in a similar period of time under similar circumstances. Now, the second, a sense of lack of control over eating during the period, or let's say the feeling that one cannot stop eating or control what or how much one is eating. Now, on the second diagnostic criteria, we have the recurrent inappropriate compensatory behaviors in order to prevent weight gain, such as self-induced vomiting, misuse of laxative, diuretics, and other medications, or even fasting or excessive exercise. Now, the third, the binge eating and inappropriate compensatory behavior both occur on average at least once a week for 3 months. Now, the Criterion D, or the fourth criterion, tell us that self-evaluation is unduly influenced by body shape and body weight. So, unlike the anorexia nervosa. So, the disturbance does not occur exclusively during episodes of anorexia nervosa. So now let us specify if in partial remission, after a full criteria for bulimia nervosa is previously met or were previously met, some but not all of the criteria have been met for a sustained period of time. Or in full remission, a full criteria of bulimia nervosa is met, and then none of the criteria have been met for a sustained period of time. Now, that's what I'm saying a while ago. We have the level of severity under the bulimia nervosa. So the minimum level of severity is based on the frequency of inappropriate compensatory behaviors, as you can see on the screen. Yes. So the level of severity may be increased to reflect other symptoms and degree of functional disability. So for the mild bulimia nervosa, we have an average episode of 1 to 3 episodes of inappropriate compensatory behaviors per week. Now, on the moderate, an average to 4 to 7 episodes of inappropriate compensatory behaviors per week. And for severe bulimia nervosa, an average of 8 to 13 episodes of inappropriate compensatory behaviors per week. Now, on the extreme side, or the extreme bulimia nervosa, an average of 14 up to more episodes of inappropriate compensatory behaviors per week. So it's like, or it could be that twice a day, or like in a day 3 times, or in other days 1 time, or maybe something like that. So on the details, the diagnostic features of bulimia nervosa tell us that there are 3 essential features of this disorder. So first is the recurrent episode of binge eating to pass the criterion A, and recurrent inappropriate compensatory behaviors to prevent weight gain to pass the criterion B, and a self-evaluation that is unduly influenced by body shape and body weight to pass the criterion D. To qualify for the diagnosis, the binge eating and inappropriate compensatory behaviors must occur on average at least once per week for 3 months to pass the Criterion C. Now, an episode of binge eating is defined as eating in a discrete period of time of an amount of food that is definitely larger than most individuals would eat in a similar period of time under similar circumstances, as said in the Criterion A sub 1. So the context in which the eating occur may affect the clinician's estimation of whether the intake is excessive. For example, a quantity of food that might be regarded as excessive for a typical meal might be considered normal during a celebration or holiday meal. Also, in the Criterion A sub 2, it is said that in order to satisfy it, an occurrence of excessive food consumption must be accompanied by a sense of lack of control to be considered an episode of binge eating. Now, an indicator of loss of control is the inability to refrain from eating or to stop eating once started. The impairment in control associated with binge eating may not be absolute. For example, an individual may continue binge eating while the telephone is ringing, but will cease if a roommate or spouse unexpectedly enters the room. So, some individuals report that their binge eating episodes are no longer characterized by an acute feeling of loss of control, but rather by a more generalized pattern of uncontrolled eating. Now, another essential feature of bulimia nervosa is the recurrent use of inappropriate compensatory behaviors to prevent weight gain, collectively referred to as the purge behavior or simply purging. So that is said in a Criterion B. Many individuals with bulimia nervosa employ several methods to compensate the binge eating. So vomiting is the most common inappropriate compensatory behavior. And the immediate effects of vomiting include relief from physical discomfort and a reduction of fear of gaining weight. In some cases, vomiting becomes a goal in itself, and the individual will binge eat or the individual will binge eat in order to vomit or will vomit after eating a small amount of food. Now, individuals with bulimia nervosa may use a variety of methods to induce vomiting, including the use of fingers or instruments to stimulate the gag reflex. So, individuals with bulimia nervosa place an excessive emphasis on the body shape or weight in their self-evaluation, and these factors are typically extremely important in determining the self-esteem to pass the Criterion D. Now, individuals with this discomfort or this disorder may closely resemble those with anorexia nervosa in their fear of gaining weight, in their desire of losing weight, and in the level of dissatisfaction with their bodies. However, a diagnosis for bulimia nervosa should not be given when the disturbance occurs only during the episode of the anorexia nervosa to satisfy the Criterion E. Now, on the associated features supporting diagnosis, it said that individuals with bulimia nervosa typically are within normal weight and overweight. So that's the difference between anorexia and bulimia nervosa. So the weight range or the body mass index is less than 18.5 and or greater than 18.5 but is less than 30 in the adults. The disorder occurs both in uncommon among obese individuals. Between eating binges, individuals with bulimia nervosa typically restrict their total caloric consumption and preferentially select a low-calorie diet food while avoiding food that they perceive to be fattening or likely to trigger a binge. Like, when we try to order, people like this tend to order most commonly the Coke Zero for thinking that it has low calorie. So menstrual irregularity or amenorrhea often occurs among females with bulimia nervosa. It is uncertain whether such disturbances are related to weight fluctuation or to nutritional deficiencies or to the emotional distress of the woman. So on the prevalence of this disorder, 12-month prevalence of bulimia nervosa among young females is 1% to 1.5%. So point prevalence is highest among young adults since the disorder peaks in older adolescents and young adulthood. So less is known about the point prevalence of bulimia nervosa in males, but bulimia nervosa is far less common in males than in females, with an approximately 10:1 female to male ratio. So the development and course, bulimia nervosa commonly begins in adolescence or young adulthood. Onset before puberty or after the age of 40 is quite uncommon. But the binge eating frequently begins during or after an episode of dieting to lose weight. Experiencing multiple stressful life events also can precipitate onset of the bulimia nervosa. Significantly elevated risk for mortality, all-cause, and suicide has been reported for individuals with bulimia nervosa. And the crude mortality rate, again the CMR, for bulimia nervosa is nearly 2% per decade. So the diagnostic crossover from initial bulimia nervosa to anorexia nervosa occurs in a minority of cases, 10% up to 15%. Individuals who do experience crossover to anorexia nervosa commonly will revert back to bulimia nervosa or have a multiple occurrences of crossovers between these disorders. So a subset of individuals with bulimia nervosa continue to binge eat but no longer engage in an inappropriate compensatory behavior, and therefore their symptoms meet the criteria for binge eating disorder or other specified eating disorder. So the diagnosis should be based on the current, let's say, clinical presentation or the past 3 months of the occurrence. Now, on the risk and prognostic factors of the bulimia nervosa, we have 4. First is the temperamental. Weight concerns, low self-esteem, depressive symptoms, social anxiety disorder, and overanxious disorder of childhood are associated with the increased risk of the development of the bulimia nervosa. In the environmental, internalization of a teen body ideal has been found to increase the risk for developing weight concerns, which in turn increase risk for development of bulimia nervosa. Individuals who experience childhood sexual or physical abuse are at increased risk of developing bulimia nervosa. Now, on the genetic and physiological, childhood obesity and early pubertal maturation increase the risk of bulimia nervosa, but familial transmission of bulimia nervosa may be present, as well as a genetic vulnerability for the disorder. So some course modifiers are also risk. Severity of psychiatric comorbidity predicts worse long-term outcome of bulimia nervosa. Now, on the culture-related diagnostic issues, the bulimia nervosa has been reported to occur with roughly similar frequencies in most industrialized countries, including the United States, Canada, and many European countries like Australia and even Japan, New Zealand, and South Africa, quite similar to the anorexia nervosa. In clinical studies of bulimia nervosa in the United States, individuals presenting with this disorder are primarily white. However, the disorder also occurs in other ethnic groups with a prevalence comparable to estimated prevalence observed in these white samples. So on the gender-related diagnostic issues, the bulimia nervosa is far more common in females than in males. So males are especially underrepresented in the treatment-seeking samples for the reasons that have not yet been systematically examined. On the diagnostic markers, no specific diagnostic test for bulimia nervosa currently exist. However, several laboratory abnormalities may occur as a consequence of purging and may increase diagnostic certainty. These include fluid and electrolyte abnormalities such as hypokalemia, which can provoke cardiac arrhythmias, and hypochloremia and hyponatremia. Now, the loss of gastric acid through vomiting may induce a metabolic alkalosis or the elevated serum bicarbonate, and the frequent induction of diarrhea or dehydration through the laxative and diuretic abuse can cause metabolic acidosis, and in some individuals with bulimia nervosa exhibit mildly elevated level of serum amylase, probably referring to the increase in the salivary isoenzyme. Now, physical examination usually yields to no physical findings. However, inspection of the mouth may reveal significant and permanent loss of dental enamel, especially from lingual surfaces of the front teeth due to the recurrent vomiting. These teeth may require chipped or may become chipped and appear ragged in the moth-eaten term. There may be also an increase in frequency of dental caries. So moving on, we have the suicide risk for this disorder or the bulimia nervosa. So the suicide risk in this is elevated, and the comprehensive evaluation for individuals with this disorder should include assessment of suicide-related ideation and behavior as well as other risk factors of suicide, including the history of suicide attempts. So, functional consequences of bulimia nervosa: the individuals with this disorder may exhibit a range of functional limitation associated with the disorder. So, a minority of individuals report severe role in impairment, with the social life domain most likely to be adversely affected by bulimia nervosa. Now, on the differential diagnosis, first is the anorexia nervosa and the binge eating purging type. So individuals whose binge eating behavior occurs only during the episode of anorexia nervosa are given the diagnosis of anorexia nervosa on the binge eating and purging type, and should not be given an additional diagnosis of bulimia nervosa. For individuals with the initial diagnosis of anorexia nervosa who binge and purge, but whose presentation no longer meet the full criteria for anorexia nervosa, binge eating and purging type, like let's say when weight is normal, then a diagnosis of bulimia nervosa should be given only when all criteria for bulimia nervosa have been met for at least 3 months. Now, the binge eating disorder: some individuals binge eat but do not engage in regular inappropriate compensatory behaviors. In these cases, the diagnosis of binge eating disorder should likely be considered. On the Klein-Levin syndrome, a certain neurological or other medical condition such as the Klein-Levin syndrome, again, then there is disturbed eating behavior, but the characteristic psychological feature for bulimia nervosa, such as the concern with body shape and weight, are not presented. Now, major depressive disorder with atypical features or the overeating is common in this disorder with atypical features, but individuals with this disorder do not engage in inappropriate compensatory behavior and do not exhibit an excessive concern with body shape and weight characteristic of bulimia nervosa. So if the criteria for both disorders are met, both disorders then should be given. On the borderline personality disorder, binge eating behavior is included in the impulsive behavior criterion that is part of the definition of borderline personality disorder. If the criteria for both borderline personality disorder and bulimia nervosa are met, then both diagnoses should be given. Now, on the comorbidity with the mental disorders is common in individuals with bulimia nervosa, with most experiencing at least one other mental disorder and many experiencing multiple comorbidities. So comorbidity is not limited to any particular subset, but rather occur across a wide range of mental disorder. Now, there is an increased frequency of depressive symptoms like the low self-esteem and a bipolar and depressive disorder, particularly depressing disorder, or the depressive disorder rather. So in individuals with bulimia nervosa, yes, they are common. In many individuals, the mood disturbance begin yeah. So the mood disturbance begins at the same time as or following the development of bulimia nervosa, and individuals often ascribe their mood disturbances to the bulimia nervosa. However, in some individuals, the mood disturbance clearly precedes the development of bulimia nervosa. So there may also be an increased frequency of anxiety symptoms like the fear for social situation or anxiety disorders. So these mood and anxiety disturbances frequently remit following effective treatment of the bulimia nervosa. The lifetime prevalence of substance use, particularly alcohol or stimulant use, is at least 30% among individuals with bulimia nervosa. Stimulant often begins in an attempt to control appetite and weight. So we are down to the last major disorder under the feeding and eating category, and this is the binge eating disorder with an ICD-9 code of 307.51 and ICD-10-CM code of F50.8. Now this disorder or the binge eating disorder has a five diagnostic criteria, and first on the list is the recurrent episode of binge eating. An episode of binge eating is characterized by both of the following: eating in a discrete period of time, like within 2 hours, and amount of food that is definitely larger than what most people would eat in a similar period of time under similar circumstances. And second is a sense of lack of control over eating during the episode, or for example, a feeling that one cannot stop eating or control what or how one is eating. So basically, this first on the list, the first criterion is similar to the criterion of bulimia nervosa because both of them actually has a binge eating related behavior. The second on the list is that binge eating behavior are associated with three or more of the following. First is the eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of feeling embarrassed by how much one is eating, and feeling disgusted with oneself, depressed, or very guilty afterward. So we have to specify on the binge eating disorder if in partial remission, binge eating disorder occurs in an average frequency or less than one episode per week for a sustained period of time after the full criteria for this disorder were previously met. And in full remission, after the full criteria of binge eating disorder were previously met, none of the criteria have been met for a sustained period of time. Also, similar to the bulimia nervosa, it do not have the the subtypes, but it has the level of severity. And first on the list is mild binge eating with 1 to 3 binge eating episodes per week, and moderate binge eating with 4 to 7 binge eating episodes per week, and on the severe case, 8 up to 13 binge eating episodes per week, and on the extreme case of binge eating disorder, it is 14 up to more binge eating episodes per week. So it could be like twice a day on a week, or like 3 times in a day and 1 time on the other day, or it depends. Now, moving forward to the diagnostic features of binge eating disorder. So, the essential feature of this disorder is the recurrent episode binge eating that must occur on average at least once per week for 3 months to pass the Criterion D. Now, an episode of binge eating is defined as eating in a discrete period of time an amount of food that is definitely larger than most people would eat in a similar period of time under similar circumstances, passing the criterion A sub 1. Now, for example, a quantity of food that might be regarded as excessive for a typical meal may be considered normal during the celebration or holiday meal. And a discrete period of time refers to the time period or the limited period, usually less than 2 hours. A single episode of binge eating need not to be restricted in one setting. For example, an individual may begin to binge in a restaurant and then continue the eating process on returning home. However, continuous snacking on a small amount of food throughout the day would not be considered as eating binge. Now, to satisfy the criterion A sub 2, an occurrence of excessive food consumption must be accompanied by a sense of lack of control to be considered an episode of binge eating. An indicator of loss of control is the inability to refrain from eating or to stop eating once started. Now, the type of food consumed during binges varies both across individuals and for a given individual. So binge eating appears to be characterized more by the abnormality in the amount of food consumed than by the craving of a specific nutrient. Also on the criterion C, it has been said that a binge eating must be characterized by marked distress and at least three of the following features. So the features are either eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amount of food when not feeling physically hungry, eating alone because of the feeling of embarrassment by how much one is eating, or could it be feeling disgusted, embarrassed to oneself, depressed, or very guilty afterwards, on the saying on the listing on the criterion B. Now, individuals with binge eating disorder are typically ashamed of their eating problems and attempt to conceal their symptoms. And binge eating usually occurs in a secrecy or as inconspicuously as possible. Now, the most common antecedent for binge eating is a negative affect. Other triggers include interpersonal stressors, dietary restraint, negative feeling related to body weight, body shape, and food, and boredom. Now, binge eating may minimize or mitigate factors that precipitated the episodes of the short term, but negative self-evaluation and dysphoria often are the delaying consequences. Now, the associated features supporting the diagnosis: binge eating disorder occur in a normal way or overweight and obese individuals. In this and it is reliably associated with overweight and obesity in treatment-seeking individuals. Nevertheless, binge eating disorder is distinct from obesity. So most obese individuals do not engage in recurrent binge eating. And in addition, compared with weight-matched obese individuals without a binge eating disorder, those with the disorder consume more calories in laboratory studies of eating behavior and have greater functional impairment, lower quality of life, and more subjective distress and greater psychiatric comorbidity. Known as prevalence, 12-month prevalence of binge eating disorder among U.S. adults aging 18 or older, females and males, is 1.6% and 0.8% respectively. So the gender ratio is far less skewed in a binge eating disorder than the bulimia nervosa. So binge eating disorder is as prevalent among females from racial or ethnic minority groups such as or has been reported for white females. The disorder is more prevalent among individuals seeking weight loss treatment than in the general population. Now, on the development and course, both binge eating and loss of control eating without objectively excess consumption occur in children and are associated with increased body fat, weight gain, and increase in psychological symptoms. So binge eating is common in adolescent and college-age samples. Loss of control in eating or episodic binge eating may represent a prodromal phase of eating disorder for some individuals. So dieting follows the development of binge eating in many individuals with binge eating disorder. This is in contrast to bulimia nervosa, in which the dysfunctional dieting usually precedes the onset of binge eating. Now, binge eating disorder typically begins in adolescence or young adulthood, but can begin in later adulthood. Individuals with binge eating disorder who seek treatments usually are older than individuals with either bulimia nervosa or anorexia nervosa who seeks treatment. Now, the remission rates for both natural course and treatment outcome studies are higher for binge eating disorder than for bulimia nervosa or anorexia nervosa. So, binge eating disorder appear to be relatively persistent, and the course is comparable to that of bulimia nervosa in terms of severity and duration. So, crossover from binge eating disorder to other eating disorder is uncommon. So, on the risk and the prognostic factor, we only have one, that is the genetic and physiological. So, binge eating disorder appears to run in families which may reflect additive genetic influences. Now, on the culture-related diagnostic issues, the binge eating disorder occur with roughly similar frequencies in most industrialized countries. It includes the United States, the Canada, and many European countries, Australia, and New Zealand. Well, in United States, the prevalence of binge eating disorder appears comparable among non-Latino whites, Latinos, and Asians and African Americans. Now, functional consequences of binge eating says that it is associated with a range of different functional consequences. It includes social role adjustment problem, impaired health related quality of life, and life satisfaction. Also, the increased medical morbidity and mortality and associated increased health care utilization compared with the body mass index matched controlled subject. Now, it may also be associated with an increased risk of weight gain and the development of obesity. Now, on the differential diagnosis, we have four different diagnoses or disorders rather. So first is bulimia nervosa. So binge eating disorder has recurrent binge eating in common with bulimia nervosa, but differs from the latter disorder in some fundamental respects. In terms of clinical presentation, the recurrent inappropriate compensatory behavior, or let's say the purging driven exercise seen in bulimia nervosa, is absent in binge eating disorder. So unlike individual with bulimia nervosa, individual with binge eating disorder typically do not show marked or sustained dietary restrictions designed to influence body weight and shape between binge eating episodes. So they may, however, report frequent attempts at dieting. So obesity. Binge eating disorder is associated with overweight and obesity, but has several key features that are distinct from obesity. First, a level of overvaluation of food, weight, and shape are higher in obese individuals with the disorder than of those without the disorder. Second, rate of psychiatric comorbidity are significantly higher among obese individuals with the disorder compared to those without the disorder. And the third is the long-term satisfaction or the long-term successful outcome of evidence-based psychological treatment for binge eating disorder can be contrasted with the absence of effective long-term treatment for obesity. Now, on the bipolar and depressive disorders, increase in appetite and weight gain are included in the criteria for major depressive episode and in the atypical feature specifier for depressive and bipolar disorders. Increased eating in the context of the major depressive disorder may or may not be associated with loss of control. So if the full criteria for both disorders are met, then both diagnoses shall be given or can be given. Now, binge eating and other symptoms of disorders or disordered eating are seen in the association with bipolar disorders. So if the full criteria for both disorders are met, so both diagnoses should be given. On the borderline personality disorder, binge eating is included in the impulsive behavior criterion that is part of the definition of borderline personality disorder. So if the full criteria for both disorders are met, both diagnoses should be given. Now, the comorbidity, binge eating disorder is associated with significant psychiatric comorbidity that is comparable to that of bulimia nervosa and anorexia nervosa. The most common comorbid disorder are bipolar disorders, depressive disorders, and anxiety disorders, and to a lesser degree, substance use disorders. So the psychiatric comorbidity is linked to the severity of binge eating and not to the degree of obesity. So this is quite the last two parts of this presentation or the discussion under the feeding and the eating disorder. So there are people who could ask that what if a person or what if you see some diagnostic criteria on a person but does not fit any of the specific disorder. Now here's the thing. So in other specified feeding or eating disorder that is classified on the ICD-9 as 307.59 and on the ICD-10-CM of code F50.8, so this category applies to presentation in which a symptom characteristic of a feeding and eating disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria for any of the disorders in the feeding and eating disorder diagnostic class. Now, the other specified feeding or eating disorder category is used in situation in which the clinician chooses to communicate the specific reason or the specific reason that the presentation does not meet the criteria for any specific feeding and eating disorder. So example of the presentation that can be specified using the other specified designation include the following. So you can see it on your screen. So first is the atypical anorexia nervosa. So this is of all the criteria of anorexia nervosa are met except that despite significant weight loss, the individual's weight is within or above normal range. So you can say that it is an atypical anorexia nervosa when all the criterion or the criteria are met except for the body weight. So it has not the severely wasted type of BMI. So you can call it atypical anorexia nervosa. Next is the bulimia nervosa of low frequency and or limited duration. So all of the criteria for bulimia nervosa are met in this case, except that the binge eating and inappropriate compensatory behaviors occur on average less than once a week and or less than 3 months. So there is one criterion that is not fully met in the bulimia nervosa of low frequency and or limited duration. Next is the binge eating disorder of low frequency and or low duration or limited duration. So in all the criteria for binge eating disorder are met in this specified feeding or eating disorder, but except that the binge eating disorder on average less than once a week and or less than 3 months. So lastly is the purging disorder. So purging disorder is the recurrent purging behavior to influence weight or shape. Let's just say the self-induced vomiting, misuse of laxative, diuretics, or other medication in the absence of binge eating. So that is the purging disorder. So next is we have the unspecified feeding or eating disorder that is also coded on the ICD-9 307.50 and on the ICD-10-CM it is F50.9. Now, the unspecified feeding and eating disorder category is used in situation in which the clinician chooses not to specify the reason that the criteria are not met for a specific feeding and eating disorder, and includes in which there is insufficient information to make a more specific diagnosis, like let's say an emergency room settings. So that concludes all the discussion under the feeding and eating disorder. Thank you for listening.